ladies and gents, if you don't know Dr. Mark Swain, he is eminent PBC specialist. He has been leading the field for many years in the area of fatigue. Um, I'm not going to put words in his head, or I'm not going to put words in your head in terms of what's coming, but this is amazing science and data that is coming from incredible work that's been done. Mark, we are so grateful to have you today. So I'm going to hand you over now. So they will not be able to see you, but they can see your slides and they can see you controlling your slides.
Okay, thanks so much. Good afternoon, everyone, and thanks for having me speak to you this afternoon. I guess it's 7:30 in the morning here in Calgary, but I'm going to talk to you today about fatigue and PBC, which I recognize is dear to many of your hearts with regards to symptoms. But I'm going to talk about some of the work we've done, which hopefully will put fatigue in a different light and a different perspective for many of you, and also allow you to have a different conversation with your physicians about your fatigue. So broadly, fatigue is the symptom with the greatest impact on PBC patients. So pretty well every study that looks at people with PBC, fatigue is their most common symptom. It's moderate to severe in 40 to 80% of people with PBC when they check off questionnaires like the PBC-40 or fatigue severity scale. It's more prevalent on when people fill out questionnaires actually than when they talk to their physician. There's a lot of debate on why that might be, but we all know people are usually more comfortable in checking something off on a questionnaire than having a face-to-face discussion with their physician. Hopefully that'll change over time. Women are typically have higher fatigue scores than men, not just in PBC, that's broadly across society. It's more common in younger patients, and it's weakly associated with disease duration. It does have a significant impact on quality of life, but especially in those where their fatigue leads to social withdrawal, so withdrawing from social activities. It's commonly associated with altered mood, things like depressive symptoms, anxiety, and there are similar levels of these altered mood aspects in men and women. Patients with higher fatigue scores are more vulnerable to emotional stress, and they're more likely to worry. And there are significant potential overlays of because everyone is different, so everyone has there's different coping skills, there's different levels of resiliency, personalities are different, so our support networks are commonly different. People who have a disease and feel they have perceived loss, fear about the future, all of these affect people differently, and they're going to impact a symptom like fatigue as well. It's important to recognize, I'm sure you all know this, is that it's very clear that URSO, although it improves survival, and in fact, people that are full responders to URSO really have normal survival compared to matched people without PBC in society. However, URSO has no impact on symptoms. I've just highlighted fatigue, but you can see all of the symptom groups are not impacted by URSO, and this has been shown in many studies. So when I think about fatigue, I actually break fatigue down into two sort of constructs because I think that allows us to think of it in a way that it allows us to target it in different ways. So when I'm thinking about fatigue, I think of central fatigue. So this is fatigue that is generated inside the brain, and then peripheral fatigue. So when one is thinking about peripheral fatigue, this is really linked to problems with the nerves that go to muscles, or dysfunction of the muscles themselves. So whether it's metabolism or other issues within the muscle, and the hallmark of that is classically weakness. So people that have peripheral fatigue typically have a weakness associated with that. So what about central fatigue? What about this fatigue that comes from the brain? Well, you can divide central fatigue into two aspects. Subjective means it's what a person says or feels. Often you address it by questionnaires. Objective means that you do something to actually measure it. And so when you look at subjective aspects of central fatigue, there are three main components, and three main components to both of these: physical fatigue, mental fatigue, and lack of motivation. So in physical fatigue, a person might say something like, I have difficulties performing physical tasks, which would be reflected in a questionnaire. With mental fatigue, it's I have difficulties concentrating or I'm forgetful. And so the often patients will describe this as brain fog. And then the other component is lack of motivation, where I don't really want to do anything. I don't want to get up and do that. Those kinds of thoughts or complaints. Whereas on the objective side, for physical fatigue, yeah, if someone say ask someone to walk on a treadmill, and they have a reduced performance, so they don't go as far, well, that's an objective measure of fatigue. People often say that's peripheral fatigue, but actually most commonly it's central fatigue. People just typically get tired and stop walking. It's not necessarily a weakness thing. Lack of motivation. So if someone has a recognized reward as part of a structured sort of process to look at fatigue, and they're given either fictional or real rewards, they often will do less work towards achieving that reward. And then mental fatigue is when you're given a cognitive task. So that's a task like doing a computer matching things, something like that. You have a tendency to get tired and not be able to complete it more rapidly. So these are the difference, and this is central fatigue. Also, when people have central fatigue, they commonly have other associated symptoms. So fatigue in PBC is the biggest symptom, and in most diseases it is. But things like social withdrawal, loss of motivation, this cognitive impairment or brain fog, mood changes like depression, anxiety, and disrupted sleep are all very commonly associated with fatigue in PBC and any central fatigue. So in PBC, I'm gonna show you why I believe very strongly that the fatigue by far is most commonly central in nature. Now, there was this a very nice sort of piece that was put together by David Jones and a patient I'm sure you're all quite familiar with. That was published in the BMJ a number of years ago, 2012. But I think it very accurately reflects many people's experience with fatigue in PBC. So these are all direct quotes. I could stay in bed until lunchtime. I have problems with my memory. It's mind numbing. You feel as if you're in a fog. You can hardly lift one foot in front of the other. Everything is so difficult. I would consider any treatment that might improve my fatigue. So these are classic symptoms of central fatigue or classic subjective symptoms. And so the issue, though, is that because the many, like all symptoms, by their nature, they're subjective. It's how someone feels. It in a busy physician's practice, it's often easy to channel those and say, well, this is just all in your head. And so, unfortunately, whenever there are subjective symptoms like fatigue, they often get put into these silos where it's all in your head. It's just you. You've just got to get over it. And so these kinds of things uh, uh, often make I think put patients in a position where they don't really want to discuss them with their physician. And this is why they're more commonly reported on questionnaires as opposed to directly to their physician, because they don't want to have these judgments being made about their mental being or mental capacity. So I'm going to show you some data from our group here that I think sheds a different light on what's happening in the brain in PBC and why there are objective things that we can look at. So measurable things that show the brain is changed in PBC. So what we do know is that in PBC, you're getting destruction of these small little bile tubes in the liver by the immune system. So you get these blue sort of accumulation, which are immune cells, which will release all kinds of stuff into the blood. And as part of that, there has to be a signal from the liver, which is where the disease is in PBC, to the brain. And that signal has to change brain function to to generate behavior, because all of our behaviors, all of our symptoms, all of our behaviors, all of our actions come from changes in the brain. And so there has to be that link between the liver, the brain, and our behaviors. And actually, when the current theories that look at central fatigue really view it as a balance between motivation, so that's the effort required to do something, against the potential reward as it relates to every action we take. So we often think, well, do I want to go to the store? Well, the motivation, I'm going to go to the store because I'm going to get food, and I'm really interested in getting that. But maybe I just don't feel like doing it because I have food in the house. So that's a very simple example of motivation and reward. However, we do it with every action that we do, for every little thing that we do. Uh, we are subconsciously making these balanced decisions on motivation and reward, because that's how we survive in a world, say, when we were just coming as a species. You have to balance the reward you're going to get from any action that you undertake, which takes energy. And this balance is very tightly regulated by different brain regions that continuously talk to each other, and that's happening all the time, even when we're sitting not thinking about anything or doing anything. And so I'm going to mention two brain regions in a number of sort of areas as I go forward. So it's just important that everyone recognizes these brain regions as for what they are. So the two brain regions, one's called the basal ganglia, and it's important and it's in the red circle here, and it controls movements, learning, cognition, so this clarity of thought or brain fog, and our emotions. And then there's the limbic system in the green, which is actually called the emotional brain, and it has the amygdala and hippocampus. It doesn't really matter. I'm just going to call them basal ganglia and the limbic system as I go forward. And these two systems or networks talk all the time, and they are very important in regulating symptoms such as fatigue, and they've been implicated very strongly in fatigue. But they also talk to different parts of the brain, and that continuous talking is very important for us to not have fatigue. And so what we've done in Calgary is we have access to our research functional a research magnetic resonance imaging facility, so MRI, and this is what it looks like. And we're using something called functional MRI, which I'll tell you about in a second what that is. But we've been using that to look into the brains of our patients with PBC, to try to find changes in the brain that can be linked to symptoms such as fatigue, and that are a hallmark of PBC. So when we look at a group of PBC patients, they all tend to have a tendency to have them, compared to people that don't have PBC. And when we typically think of MRI, I think I'm sure many of you have had MRIs. Often they're used to look at structural changes. So you look at a brain and you say, okay, this person has a tumor, or they have a stroke, or things like that, and they're extremely useful for those kinds of things. But using the exact same machine, you can actually take out different data, and that data we use to in something called functional MRI, because it's really looking at function. And so what functional MRI does, it doesn't look at the structure. It looks at changes in how much oxygen is being carried in the blood, and there lots of blood flows through our brain, and the changes in in the blood flow in the brain that occur when the brain is being active. So when a brain area is more active, it has to consume more oxygen. So it has to pull more oxygen out of the blood as the blood goes by. And when it pulls more blood out of the oxygen, then our body is conditioned to send more blood to that area, and that's what functional MRI does. It says, okay, if a brain area is active, it's pulling more oxygen out of that blood that goes by, and the more blood is going to that area because it's active. You can show it in images like this, which are created by computers. This is not like a mass in your head that you see with standard MRI. And you could use the functional MRI to look at activity of neurons. So neurons are the pieces of the brain that carry the electrical impulses, which really is what makes the brain work. So you can look at neuron activity in a specific brain region. You can look at the connection between different brain regions that talk to each other. And then if they talk to each other all the time, even when we're at rest, those areas are considered a neural network. And they can also be used, and I'm going to show you one little piece that they can actually be used to define areas of the brain that have inflammation going on in the brain, despite the fact that in PBC, the inflammation that we all think of as being in the liver, not in the brain. So when you're looking at neural activity or activity of the brain in one region, so look at this blue circle here, you can actually look at that with MRI. You can say, okay, well the activity of the neurons in that part of the brain are either more active, less active, or the same as people that don't have PBC. And they call it ALF. I won't tell you what that means, but what it stands for. But basically, a higher ALF score means that the neurons in that area of the brain are more active. A lower score means that they're less active. And then when you look at different regions, so say the same region now is green, it's connecting all the time to different parts of your brain. And how it connects to that part of the brain is part of network. It can be part of many different networks, but it's part of networks. And those parts of the brain are talking to each other all the time. And if they're talking and they're very synchronous, that means that their activity is at the same time. That means they have a strong functional connection. If they don't talk very often or they seem to be out of sync, then that's a weak functional connection. So I'm going to talk now about some of the fMRI, this functional MRI stuff that we've done in PBC patients. And what we did is we looked at functional connectivity strength. So this is how closely these areas are talking to each other in synchrony between brain regions, these brain regions, the basal ganglia and the limbic system. And what we found was that in PBC patients as a group, compared to people without PBC, there's enhanced connectivity strength, which means there's enhanced talking between those brain regions in the PBC group compared to the non-PBC group. And so what that means is that in PBC patients, the basal ganglia, so this reward processing, movement related, cognition or brain fog regulating sort of area, and the limbic system, which is really important for motivation, reward, emotion, learning, memory, they're more strongly connected than people that do not have PBC. And so what this means, I'm not sure, because this is just sort of showing that there's differences, but what it shows is that very clearly that the brains in PBC patients are behaving differently with regards to how these two very important brain areas talk compared to people that don't have PBC as a group. And so there are other changes in connectivity or these kind of connections between other brain areas and PBC patients that maybe are linked to fatigue. So what we did was we did the same tests in patients that have PBC, but we also assessed them for their level of fatigue. And in this particular study, we used the PBC-40 scale, but we also used the fatigue severity scale, which is this sort of scale. A number of you may have done before as a way of assessing fatigue. And one area that we looked at is this area called the thalamus. So it's shown, I've highlighted here in this blue circle. And what the thalamus does, the thalamus is a kind of an amazing area. It's like a train station where all the trains come to it, and then they all go to different parts of the country. So basically, all of the senses that we feel, except for smell, any sense we feel from our bodies, so you feel your bowels moving, you feel your heart racing, you feel temperature, you feel touch, all of these things, sight, everything, they all come through the thalamus. And all of those senses go to the thalamus and then they're relayed to the higher senses of our brain. This is called the cortex up here. And the cortex is the part of our brain that processes all these different sensory inputs and then shoots down things telling us what to do about it. So basically it processes things and it says, okay, well, the best action is to do this or that. Not things like if you touch a hot plate or something like that. That happens at a very lower level. It doesn't go up to your brain. You pull your hand immediately from the hot plate. Here, this is processing much higher thoughts about, you know, uh, I don't, my stomach is sending me signals. I don't feel that great today. Maybe I shouldn't go out. And so your brain will process that and say, okay, well, maybe you shouldn't go out. And so it'll send signals down and then you don't go out, basically. And also the thalamus is part of the motivation and reward systems in the brain. And so when we use functional connectivity, I don't want you to get freaked out by saying that, all these brain, but basically when you do functional MRI, you show the information that you get as a comparison between two groups. So this is not an image of one person. This is an image of a group of PBC patients that have fatigue compared to a group of PBC patients that don't have fatigue based on that fatigue severity scale. And what you can see is, so I've just highlighted these blue areas. These areas at the front of the brain are very important for a number of different things. And what PBC patients who are fatigued show compared to ones that are not fatigued, they have decreased connectivity between their thalamus and the cingulate cortex, which is one of these parts, and the prefrontal cortex, which is this, which are very important parts of the brain for reward-based decisions. So this motivation reward thing. And then also for the prefrontal cortex is very important in helping us process our thought, as they say, intelligently process our thoughts. And so it process our thoughts, our actions, and emotions so that we can do stuff about them. And so these areas are very important for regulating many behaviors that are felt to be altered in PBC patients that have fatigue. And you can see that fatigue itself is associated with changes in the connectivity between the thalamus and these areas, decreasing it. But also, if you look at this area here, which is this is another part of the cortex, so that upper part of the brain, there's increased functional connectivity uh, between the thalamus and this area of the brain in fatigue versus non-fatigue patients. And this part of the brain is very important for interpreting sensations from the body and then preparing us to do actions as it relates to those. So there's a difference between the connectivity of the thalamus and these brain parts in PBC patients that are fatigued versus non-fatigue. There's another part of the brain that's in this basal ganglia. So that basal ganglia, remember we talked about the limbic system and the basal ganglia. Well, one part of the basal ganglia is called the putamen, and it's very important for learning and motor control, reward. Again, we're coming back to reward, and this cognition, thinking clearly, or brain fog. It plays a very important role in controlling those. And so when you look at this neural connectivity, so just look at the green areas here. In PBC patients that are fatigued versus non-fatigued, there's increased functional connectivity, so increased talking between the putamen and these green cortical areas, and those are the areas that prepare us for movements depending on what the sensory inputs from our body are telling us in fatigue versus non-fatigue patients. So again, fatigue in a group of PBC patients is changing how that part of their basal ganglia talks to their higher brain compared to non-fatigue PBC patients. So not only does the brain change in PBC, but it's changing in people with PBC that are fatigued versus non-fatigue. So, are there any other changes in the brain in PBC patients compared to healthy controls that might regulate behavior independently of fatigue? So I'm going to go back to the thalamus, so this relay station. So when you look in a group of PBC patients and you compare them to healthy controls, what we find is that the thalamus in PBC patients is smaller. It's reduced in size by about 5 to 10%. And so you go, well, 5 to 10%, really, does that make a difference? Is it really important? Well, that that change in size of thalamus is what's seen in patients with multiple sclerosis. And I think we're all pretty comfortable and confident that multiple sclerosis is a neurological disease which causes significant impairment and generates significant symptoms. Also, PBC patients had decreased neural activity. So this ALF measurement that I mentioned is lower in PBC patients than controls. So their neurons seem to be firing at a lower level than a group of healthy controls. So again, what does that mean? Does it mean anything? Well, when you look at just a group of healthy controls, if they're found to have decreased thalamic neural activity, so this decreased ALF, and then you get them to do a cognitive task like working on a computer to match numbers or things like that, They're actually more likely to become fatigued and stop that task than individuals that have a higher level of neural activity in their thalamus. So again, you could see that if PBC patients are starting off with a lower thalamic neural activity, they might be more prone to becoming more mentally fatigued with mental tasks. There's another part of the brain called the hippocampus. Although it's relatively small, it's an extremely important part of the brain for numerous behaviors that humans do. It's very important for controlling mood. It's been strongly implicated in depression. And in fact, a smaller hippocampus is felt to be the most reproducible evidence on MRI of major depressive disorder. It's important for cognition, so clear thinking, regulating brain fog, very important for memory, and very important for movement. And so using MRI, we can actually look at the size of the hippocampus in PBC patients. This is just a little square showing where it is. And you can see here's a PBC patient down here, right, left. This is a control. And even without even doing mathematical kind of testing, you can see this is smaller than that. And this is a little bit smaller than that, but this is quite evident there. But when you actually look at it and measure it in a group of PBC patients and compare them to healthy controls, the hippocampal size is significantly smaller in PBC patients by about 5% compared to compared to healthy controls. So again, 5%. Is that such a big deal? It doesn't seem like much, right? 5%, just a little bit. Well, when you look at when you look at this degree of hippocampal volume loss or size loss in PBC patients, it's the same as a percentage as what you see in patients with major depressive disorder, but not just them, but also in other neurodegenerative diseases like multiple sclerosis, Alzheimer's disease, and schizophrenia. So if I told you that the hippocampal size was changed in someone with schizophrenia, there's no one in the world would say, "Oh, that's not important." But if I tell you it's smaller in PBC patients, I think it doesn't get the same sort of PR as it should be getting, because this is a significant change, and it's recognized in these disorders to be linked to decreased cognition. So this brain fog, I guess is the way to put it. I'm going to now turn to something called QSM. It doesn't really matter what that stands, but just QSM is fine. So QSM is another thing. So using the same MRI image or data that we get out of the standard MRI scanner, we can actually use that to measure something called QSM. And what QSM is, it really looks at iron deposition in tissues. So when you get inflammation in the brain, iron gets deposited. And so and so that's felt to be an indicator, a very good indicator of what's called that means brain inflammation. And so they use it quite regularly in patients with multiple sclerosis and Alzheimer's as a way of mapping areas of the brain that are inflamed. And so people, when you're talking about neurological disease like multiple sclerosis and Alzheimer's disease, people are very comfortable saying, okay, well, that's inflammation. We're going to treat this. We're going to fix that inflammation. It becomes a target or something to follow in the brain, because people are recognizing quite clearly that inflammation is a very important part of neuroinflammatory diseases. And when you get it neuroinflammation, it's commonly associated with these memory defects, problems with cognition, brain fog. So what about PBC patients? Well, they have a liver inflammation, so they should not be having brain inflammation, but they do. So when you look in the hippocampus, so that part of the brain that's so important, that's reduced in size by 5%, controls emotions, thinking, memory, all of these things. Well, there's increased QSM or iron deposition in the hippocampus of PBC patients as a group compared to healthy controls, of similar magnitude that you would see in these neuroinflammatory diseases like MS and Alzheimer's. And so can you look at the brain in other ways? So that I've been talking about MRI, which obviously we've spent a lot of time on. It can tell us a lot of information, but are there other techniques that you can use that might support a brain change happening in PBC? Well, we turn to this technique called near infrared spectroscopy, or the short form is just NIRS. So I mean, most people would, their eyes would glaze over when they hear the word NIRS or this, but actually anyone that goes to see the doctor, if you go to emergency or whatever, or during COVID, of course, these were widely available. You clip this little thing on your finger and it shines this red light. So near infrared light through your finger, can go right through the bone in your finger, and it tells how much oxygen. So we're all pretty comfortable. You clip that on and it says 98%. Well, your oxygenation is excellent. If it says 70%, then you're in big trouble and you're probably going to be in the hospital for a while. And so this is quite a robust way of looking at oxygenation of tissues. So we decided to apply this, and there are ways to do this to the brain. And essentially, what you do is you put a source of the light, so the same as on the finger. You shine that light through, and it goes down through the skull and through the brain. It goes about 3 to 5 centimeters deep in the brain, and then it comes up to these detectors. So you can go and you can look at the cortex, this upper sort of part of the brain, that's so important for processing all of this information that we get and then sending what to do down to the rest of the body. So we did this in PBC patients versus healthy controls. And what we found was that when you look here, so you can put just a metal, you can put a plate on the front here, which is called the frontal cortex. And that's very important for regulating behavior, many behaviors that generate symptoms that are quite commonly seen in people with PBC. What we found was the brain oxygenation, so how much oxygen is in that tissue in the frontal cortex, so that part of the brain in PBC patients, is decreased. Here it is, compared to the control group. Again, you go, well, that doesn't sound good, but does it really mean anything? Like, does it really mean something if you have a little bit less oxygen in your frontal cortex or not? Well, again, I'm going to turn to another disease that everyone's pretty comfortable. It means a lot, and that's multiple sclerosis. So if you look at multiple sclerosis, this is actually the same thing. This is oxygenation of that same, doing the exact same test. In fact, this study was done here in Calgary, so it's exactly the same machine, exactly the same setup and everything. You can see as people with MS, as their disability from MS goes higher, which is on the bottom as it goes from left to right, you can see their oxygenation of their frontal cortex drops off. And it drops off in a magnitude or a level that's the same as PBC patients. So if I told you that people with multiple sclerosis that were having significant symptoms and impairment had a brain as cortical oxygenation level that was here, you go, oh, that's something I need to be concerned about. But the same thing's happening in PBC, and I think we need to pay more attention to this. I'm going to turn to fatigue now, just to finish off as a therapeutic target in PBC, because this is becoming more and more of a target. It's going to be more and more relevant to many of you that experience fatigue. So I'm going to just come back and say it's very clear that URSO, although it improves survival, and it's been an amazing development in the treatment of PBC, it does not change symptoms, which is part of the problem, of course, because you're creating people that well, it's sort of the silver and non-silver lining is that the silver lining is that people are living much longer with PBC and can have a normal lifespan. The problem is if you're not impacting symptoms, then they're living that prolonged life with symptoms that can be quite incapacitating. So the first drug I'm going to mention is bezafibrate. Many of you may have heard about it. It's an add-on drug. It's been a very nice study came out in the New England Journal not that long ago. It's a pan-PPAR agonist. PPARs are a group of drugs that are being developed for PBC, and there are a number of them, and they target different ones of these receptors. And this study that came out, this is called the Bezerso trial, as I mentioned, is in the New England Journal. It suggested there was an improvement in fatigue, although the scale used here would not be a classical scale, but I think it still suggests that there's an improvement in fatigue. However, the confounder is that in about half the patients who are treated with bezafibrate, their itch gets better. And so when their itch gets better, and the feeling is that people are sleeping better and their itch is gone, then that can, in its own right, improve fatigue. So is this effect on fatigue itself, or is it an effect on fatigue that really is driven by an improvement in their itch? And that's unclear still. There's another drug called seladelpar. it's a PPAR delta agonist. So bezafibrate's more of an alpha agonist, but it does have some delta effects. And it also, there's some suggestion from this study, which just came out just about a year ago, that it does improve fatigue. And I just look, if you look at the bottom, it doesn't matter what all these things are, but if you look, basically this is treatment with seladelpar at 1 year. And basically, if you're on the side over here in green, that means that your fatigue domain in the PBC40 improved. If you're over here in red, that means it worsens. And I think if you just look at this without trying to count any numbers, there's significantly more green than there is red. And so there is, I think this is certainly evidence that there appears to be a benefit with regards to fatigue with seladelpar treatment. However, again, like the bezafibrate, this improvement in fatigue paralleled an improvement in itch in these patients. So is this being driven by an improvement in itch, which helps their fatigue? It remains unclear. Obviously, if you're improving itch and improving fatigue, to someone who's got those symptoms, it doesn't really matter because improvement is improvement. But are they independent? It's unclear. There's this study that just recently came out is quite exciting because I think it's the first study that shows that fatigue can be impacted independent of itch. So this drug is called setanaxib, and it inhibits something, this enzyme called NOx, and it's quite specific for these two enzymes, the 1 and 4 types. And what they showed was that so this is placebo. This is the lower dose of setanaxib, and this is the higher dose. And then the top panel are people that had a FibroScan that was less than 9.6 kilopascal, and the bottom panel are people that had a FibroScan greater than 9.6 kilopascal. So higher liver stiffness, probably more liver stiffness, more liver fibrosis, a more advanced disease in in the bottom group than the top group. But what you can see is that this is the fatigue score from baseline to week 24 from the PBC40, and you can see that individuals on this medications appeared to have their fatigue improved, and probably more evident in the people had more sort of more advanced liver disease. So, and setanaxib did not significantly alter itch score. So this is the first study which suggests that that fatigue itself can be targeted and can be improved, and it doesn't it's not being driven by an improvement in itch itself. So I think this is very exciting that we can start to think about targeting fatigue in very different ways. And can we look at these changes and correlate them with changes in what we find on functional MRI and the nearest studies that I showed you earlier? I think it is a whole other exciting avenue where we can get objective findings, hopefully, with these newer medications. So just to finish off, I think many people that have fatigue, especially associated with chronic disease, are used to being told it's all in your head. Hopefully, what I've sort of showed you today shows that's totally true. It is totally in your head. But but PBC patients that have symptoms, I think a lot of these symptoms can be tied back to and attributed to changes in the structure and function of their brain, which is part of PBC, just like it's part of multiple sclerosis, it's part of Alzheimer's disease. And those brain parts that are changed in PBC are very important for controlling our behaviors and symptoms such as fatigue. So they generate, as people filling out questionnaires saying they're fatigued, they have depressive symptoms, they're withdrawing socially. All of these things are behaviors that our brain regulates. I think that the exciting thing is that rather than ignoring these symptoms, which is really what we've been done for a long time, because we're targeting on trying to improve liver outcomes, which of course makes total sense. Fatigue is now becoming a therapeutic target for new PBC treatments and approaches. I think the future is looking much brighter for our ability to treat these diseases. And that's it. I'm happy to take any questions that you might have.
Okay, so Mark Swain. First off, nobody has the right to look that good 7:30 on a Sunday morning How you do that, we will never know. Thoroughly impressive it is. Right, we've done really well. We've limited you to only 63 questions, so we'll go through them as quickly as we can. Um, awesome, amazing presentation. So thank you. First question: if liver function tests normalize, will this reduce fatigue? And if not, why not?
Yeah. So the I think that study about response is really highlights it. I think very openly. I think we all know that we know that ERSO is very good, and that 2/3 of patients are going to have a complete response. That may or may not be a normalization, but certainly it's going to be less than 1.677 times the upper limit of normal. But say they are normalized, that typically the fatigue does not improve. And so why is that? I think that is a very important question. If you look in our studies, there are some changes in the brain that do um, they're less pronounced in people that have had a complete response, there is a mixture within our studies of people that would be described as complete responders, partial responders, or non-responders, and so to dissect that out better, I think we'll need to have more patients in each group. But the concern is, and this is the concern with um, in PBC in the very initial URSO study, when you started URSO early and there was a group that was on placebo, the group that was put on placebo later, they actually did not do as well as the people that got the URSO at the beginning. And I think that we need to be thinking of treatments for that affect the brain's structure and function earlier on. And so when we have things that can target those at an earlier stage, I think we need to be addressing those early on with those therapies, because I think as you get further along, it becomes much more challenging to change that course and change those brain differences. That is my theory, although I have nothing to base that on except
Okay,
theory.
thank you. Here's a great question. I love this. So I'm going to kind of paraphrase, but do we know if the physical brain size changes happen after the diagnosis of PBC, after the development of PBC, or is it part of the early stages of the condition? What do we know?
Yeah, that's a great question, and that's something I've been thinking about for a long time, and I hopefully I'll have an answer in the next year or two. Uh, I mean, obviously, people have AMA before they have cholestasis. And people are more and more people these days, and it has historically are picked up sort of serendipitously by as having a positive AMA. It can be very high titer, and their alkaline phosphatase is normal, like totally normal, and uh, and so the question is, and if you biopsy those people, there's good studies that have shown that many of them actually have changes in their liver. They're showing immune destruction of the liver, of the bile tubes in there, but they just haven't damaged enough of them that they're getting cholestasis yet. And so the question is, are those AMA positive people that don't have an elevated alkaline phosphatase, do they have brain changes? So I mean, obviously you have to find those people, then you have to get them willing to go into an MRI scanner. But we have a pool of those people that we've done that on, and I can tell you that I believe that and we haven't analyzed that data fully because we're still collecting it, but I think in the end what we're going to see is a lot of the changes in the brain are happening before people become cholestatic. So the question is, do we actually need to be targeting AMA positive people that don't have cholestasis with regards to the brain changes to prevent them from developing symptoms later on? Because when they develop cholestasis and they're showing, which is a later form of that disease, have we missed the boat on the symptom thing, or could we do better in the and so I think that'll have to be answered when we have that data, but I think it's going to show that the brain changes are there when people don't have cholestasis.
Perfect. Thank you. Last question. Thank you so much for this. Is modafinil widely prescribed for chronic fatigue?
Yeah, so modafinil is an interesting drug. I mean, there was the initial study by David Jones came out in PBC, and I think it suggested it had some effectiveness. However, I think later studies have showed that it doesn't have much of an effect. I've tried it in PBC in my patient cohort, and I've not been impressed with it. I don't, and people don't feel well on it. They most of them describe they upsets their stomach. They don't feel well, and so I don't use modafinil at all. I've stopped using it quite some time ago. People try. I mean, it's used in narcolepsy. It's used in chronic fatigue. I think people would shift more towards there's more of these drugs that are used in like in ADHD and things like that are more stimulant type drugs. I think those are seeing more use in people that have more chronic fatigue syndrome that's unexplained, that's not associated with a disease. And so I think modafinil in PBC is not like, I really don't know anyone that's really using it much these days, to be honest.
Appreciate your answer. Thank you so much. Mark, please go and enjoy the rest of your Sunday. We are so grateful to have you with us today. So we
Thanks.
thank you very much. Ladies and gents,
My
Dr.
pleasure.
Marks again.
Yeah. Thanks, everyone. Have a great day.
Okay.